Good morning. Hi, everyone. Welcome to today's webinar, Going Beyond RPM, RTM, and Creating Real Value for Providers and Patients with DTx. My name is Cassandra Kapathakis. I'm an engagement manager at Decimal.health, and I'm very pleased today to introduce our presenter, Jethwani, as well as the topic. So at Decimal.health, we've been spending some time over the past 6 months really researching RPM and RTM, and also thinking about the value out of that to digital therapeutics and how it could be leveraged to support the growing digital therapeutics market. So we've recently published 2 blogs. You can find them on the Decimal.health website. One about remote patient monitoring. It's not new, but it's necessary. And can RPM, RTM really solve that problem for adoption of digital therapeutics? We're also in the process of publishing a white paper going through the background of RPM, what value it has, the barriers, the facilitators, and really some great case studies of RPM in the market. So today, Dr. Jethwani, who's the managing partner and CEO of Decimal.health, will be continuing his series based on DTx East 2022 to really help talk about the challenges and opportunities of gaining provider adoption of the DTx solution. He's going to discuss a framework of value for providers and patients using digital therapeutic solutions, and also think about how this framework can be translated into real revenue opportunities for digital therapeutic companies. So with that, Kamal, over to you.
Thank you so much, Cassandra, and I want to thank everyone here for joining the webinar and spending the next hour with us today. I appreciate it. As Cassandra mentioned, I'm the CEO and managing partner for Decimal.health. My background has been in sort of healthcare systems for a really long time. I spent a number of years at Mass General Brigham leading digital innovation, and as part of that, have seen firsthand how digital innovations are getting implemented and organized within health systems, how providers adopt, and what they do with it. Interestingly, one of my projects at Mass General Brigham was to explore new RPM codes that were coming out back in the day and explore whether we would have participated in those or not. And through the course of this webinar, I'll talk a little bit about what our perspectives were, whether we did it or not, and then also sort of how we can ensure success on some of these codes, but also really thinking about how we can think more broadly about digital health in general in terms of reimbursement, and how we can think about creating value for provider systems. With that, I'm going to share my screen and start to present. Just want to make sure we have the right view. Great. So as I mentioned, just sort of very, very quick background at Provider Systems, a number of years in sort of both developing solutions, validating them, and scaling them across health systems. And now over the last 3 years at Decimal.health, we've worked with over 80 companies and helping figure out how people can create value for provider systems and for pharma. And then how do we help you create the right product market fit so that you can be adopted and creating value for these solutions at providers. So to kick us off, really, I wanted to talk a little bit about what the overall macro trends are for DTx solutions, right? And as you see, one indicator of whether there's interest in digital therapeutics is sort of investment trends. Investment trends continue to be pretty strong, and we saw a slight dip in 2022 from 2021, but even then, 2022 was the second strongest year that we had for DTx investments, so still going pretty strong. About $1.6 billion in 2022 across 111 deals. But if you look at the other indicator of whether these companies are commercially viable and commercially successful, are they getting the markets as excited as they're getting private investors? What we see is that our market performance lags. And the poor market performance is coming from the investors' concerns regarding the ability for these companies to be able to drive recurring revenue. And when you look at the dichotomy of these two statistics, you start to think about what's really happening here, right? You're seeing a lot of interest in the potential for digital therapeutics, but you're not seeing that potential still yet translate into performance, into commercial viability, into revenue right away. This is a sign of a growing market, right? I mean, we're still pretty early in the trend and in the maturity curve of our industry here. And so that's probably fine. But I think that we still need to bridge the gap. We still need to translate the potential that everyone is seeing into reality. And that's really one of the things that belies that is the adoption by the end users. And in this case, the end users are patients, but more often than not, the distribution to these patients is determined by the acceptability by providers, right? So the providers can either be your biggest champions and facilitators, or they can be your biggest gatekeepers. And so one of the things that we think about a lot at Decimal Health is how do we get over that hump, and how do we always make sure that our providers are going to be our champions so that we can get these solutions in the hands of people. And when we get these solutions in the hands of people, that's when we are commercially viable. We did a pivotal survey, a provider survey, late last year. And this is the largest survey done in digital therapeutics for providers. And what our survey showed was that we had about a quarter roughly of providers that had prescribed DTx products, and 3/4 that had not. This is obviously overrepresented, so we got a bigger sample of people that might have prescribed DTx product, because if you look at the overall market, it's much smaller. And what we asked them was the reason why providers were likely to prescribe a solution. So these were the quarter that had actually prescribed a solution. Interestingly, clinical efficacy of solutions rose to the top as one of the reasons why providers are incentivized to prescribe. And the second one being that there were inadequate treatment options that existed otherwise, right? So if you think about it, if I can treat my patient with metformin adequately, then I can treat them with metformin adequately, and I'm not going to nearly be as incentivized to prescribe them a DTx solution as I might be, for example, for fibromyalgia, where existing treatment options are inadequate. So those were the two big reasons why providers are prescribing. Some other reasons around, I want to try novel treatment options, my patients are looking for it, those existed. If you look at the white space though, right, financial incentivization was 0%. Again, it's a survey, and so, it may not represent every single opinion out there. But what this survey is telling us really is that financial incentivization doesn't necessarily incentivize, right? But it definitely removes barriers to being able to prescribe this. So no provider is going to say, oh my God, I really want the $50 that RPM is going to give me so that I can, no one's getting rich on that, right? But what it does do is it values their time a little bit, and it allows them to be able to sort of, get some value for the time that they're going to be spending on it. So you still want to always think about value creation, where, is it the clinical efficacy? Is it the, being available in a space where there doesn't exist another option, et cetera? And then sort of think about financial incentivization as more of a removal of barriers. Really interestingly, the other 3/4 of providers, we asked them, would you prescribe in the future? And, about 90% of these providers said yes. So what this is telling us is that there is a real incentive, there is a real interest in the market, right? Contrary to popular belief, providers want to participate. They want to prescribe. They want to have DTx as one of the tools in their arsenal. The question is, as an industry, can we make it easier for that to happen? Can we create the systems to make it happen? And can we incentivize them appropriately to make this happen? Can DTx just become therapeutics, right? Not digital therapeutics, but just another therapeutic in their arsenal. So the good news here is that as an industry, we're trying to make this happen. And then there is also tailwinds in the ecosystem itself, right? So there's payers and reimbursement that is starting to grow. This very popular graph that we've taken looks at the current coverage for DTx, and then the interest in providing coverage by all these different types of payers. And what you're seeing is that there's a lot of people that are already providing coverage through some mechanism or not. But if you look at the interest in providing coverage, almost 50%, close to 50% across all these different payer types are interested in providing coverage. So that is very good news, because as coverage starts to increase, we start to reduce the barrier of people potentially seeing this as some alternative system, but start to seeing it more as a regular therapeutic. We also saw CMS enabling a lot of different reimbursement mechanisms as well, right? So Payer got the HCPCS code released last year, which is a huge movement in the market. We recently saw a number of other solutions gain approval for HCPCS codes as well. And then there's obviously the RTM facility or family of codes RTM being a little bit more relevant, and I'll get to that in a couple of minutes. So what we're seeing here is there is already some coverage. There is a likelihood of increasing coverage, and we're seeing very specific mechanisms being released by CMS that is basically guiding the way for other peers to maybe follow suit. So what is really interesting about, as I mentioned a couple of minutes ago about RPM versus RTM, is that with the release of RTM codes, remote therapeutic monitoring codes last year, in the middle of last year, we are now able to get reimbursement for non-physiologic data. That could be self-reported data, right? Digitally uploaded self-reported data that we were not able to get reimbursement for under the RPM codes. So that's a big difference. And the second big difference is that we're actually seeing a lot of other types of providers, physical therapists, physical medicine, rehabilitation, nurse practitioners, et cetera, as being the primary billers on RTM, as opposed to what we're seeing with RPM, which is all about physiologic monitoring. So if you just compare apples to apples, right, RPM requires the use of digital technology to capture objective physiologic data. And then you sort of look at the data and then you kind of respond to it. Whereas RTM could also include things, as I said, about non-physiologic data or self-reported data, but also things like therapy response, patient adherence, et cetera. So that's really interesting in that shift. And if you think about digital therapeutics, a lot of these therapeutics, for example, provide CBT, right? And if you look at, maybe therapy response on CBT, or if you look at the data being generated from some of those things as self-reported data, now we have a mechanism to be able to get paid for that. So it fits really well with the whole DTx philosophy and the way our solutions are designed, which is good news for the industry. So what we wanted to do was we wanted to look at data that is now publicly available. And looking at this data, we wanted to look at what the adoption curve was for RPM and what can we predict for RTM coming up. RTM is very new. It's less than a year old now. And so obviously we're at the very, very initial stages of RTM adoption. But we have more than 6 years of data for RPM. And so we're going to look at, what RPM looked like and how it grew and what changed. And then we're going to try to draw parallels and look at what RTM could look like in the next, year or so, to see where we might be going as an industry and look at whether this is going to be a big enough pie for all of our DTx companies to sort of eat from. So starting a little bit with RPM utilization, we've looked at data from 2019 to give us about a 2-year runway into the data. And what we saw was that in the last, between 2019 and 2021, we saw that the number of providers that were reimbursing for RPM grew at about a 26.5% of CAGR. So we started with about 5,000, HCPs, give or take, and then we got to about 8,000 HCPs at the end of 2021. Now, one thing to remember is that commercial payers started to adopt RPM in 2021, and so some of that activity isn't quite captured. And so that number might look a little bit different as we look at data going forward from 2021. But still, going from about 5,000 roughly to about 8,000, that's a CAGR of about 26.5% for RPM. In context, though, if you look at, okay, what does 8,000 providers really represent, right? So we looked at, and the 8,000 number again is the monthly number, right? So we looked at about 50,000 over 3 years was the number of unique qualified healthcare professionals that were billing RPM codes between 18 and 20. And if you look at the monthly number at the end of it, as I showed you, was about 8,000. That's roughly 0.8% of the total eligible number of qualified professionals that could have billed for RPM, right? So we're still under 1% adoption across the country for RPM codes, right? So that kind of puts a little bit of a reality check into how popular or how broad the adoption is or not. The other thing that we also wanted to look at was, okay, number of providers has stayed under 1%. What's the growth in terms of number of patients on this? And what we saw, even let's say just if you took the last year window between 2020 and 2021, is we saw about 19,000 patients getting added in that last year. And so that growth of patient population is also pretty modest. It's about at about roughly 3%. right? So 3% growth in a year on the patient side, and a total percentage of providers billing against these still in 2021 is under 1%. So long way to go, right? But again, the numbers are still not completely terrible, but there seems to be enough traction here where it starts to see some adoption, but nowhere near where we need it to be if we were to make this a scaled solution for our industry. Now, we looked at this and we saw another nuance within the data that I thought was really interesting. So while we saw that the number of providers were growing at about 26.5% CAGR, we looked at the number of claims on RPM. And what was really interesting is that the number of claims actually grew by 900% in that similar time span, right? So what is really interesting about that is that if the number of providers is only growing at a 26%, but the number of claims are going at 900%, there's something there. And what you end up seeing, if you look at the data really closely, is that once an HCP bills under RPM, then they continue to bill more, right? So the total average claim per HCP is 288 claims per year. So once I bill under RPM, I keep billing, I keep adding patients, and I keep billing for RPM within the same patient as well, right? So there's continuity of billing, and there's an increase and there's a scale within the provider and their behavior, because once they start billing, they keep billing. They keep billing for the same patients and they keep adding new patients, which is really interesting and very, very, very promising, because what this is telling us is that the effort we put into bringing in new providers with the fold of RPM pays off, because once they come under the fold, they keep billing, right? So it's not onerous, it's not difficult, and the dollar amount is meaningful because there is a continuity of them billing. This is very, very positive news for us. And I think what then this tells us as an industry is it's been really hard to get new providers under RPM, but once we get them in, then it's quite worth it. And that's kind of maybe one of the ways to think about it as you relate this to your own solutions as well. So now RTM is fairly new, but we wanted to kind of follow the cadence for what happened to RPM and mimic that for RTM and see if we say, hold the assumption that RTM will follow the same pathway. It may not for a lot of reasons, but let's say we hold it fairly similar. Let's see what that means for RTM adoption, right? So RTM, even though it only started in 2022, so roughly right now, 500 unique providers that submitted for billing. And so again, a much smaller number, obviously, than you're seeing for RPM, right? But about 500 providers right now that are billing for RTM in this last 6 months. The evolution for RPM, as we showed you, the CAGR that we saw, let's apply that same CAGR to our TM billing, right? And if we do that, then you're going to see about 1,000 HCPs will be expected to adopt RTM by mid-24, right? So we have another maybe year and 3 months to go for that point in time. But once we get to that point, if the same adoption curve applies, then we're going to get to about 1,000 HCPs. Now, you might argue that the growth in our TM should be faster because people who are reimbursed under RPM will just be very easily targets to go and bill under RTM. And while that might be true, one thing to remember is that we are expecting delayed commercial reimbursement for RTM. So it hasn't started yet quite as much, and that we expect the uptake to happen, but the uptake to be fairly low in 2023. So for that reason, now you're mapping only non-commercial patients on this, and which is why we're saying maybe the 26% CAGR is actually reasonable, and maybe even a little bit optimistic. So if we follow the same trajectory for RTM as we follow for RPM, we're seeing about 1,000 providers adopting and starting to use RTM. Now, if you, again, get very ambitious and you say, let's assume that 288 claims per HCP, let's assume that RTM achieves the same amount of scale as RPM per HCP, now you're going to start to see that the total market would be about 280,000 claims in 2024, which ends up being between $12 and $14 million in revenue across all providers in the United States across all therapeutic areas, right? So now think about the number of DTx companies we have that potentially want to use RTM as a mechanism for reimbursement, and the entire pie is about $12 to $14 million in the entire year across the country. That number is small, right? So there's a lot of things we can do about that as an industry, but just wanted to give us that perspective, right? On yes, this is an interesting mechanism. Yes, that if our numbers are wrong by a little bit, let's say that it doubles to 2,000 providers in some reason, or maybe the claims go up a little bit, right? We're still working within a margin of error, right? The number doesn't automatically become the billions of dollars that we need it to become for everyone in the industry to sort of get very excited about this. So the number is fairly sobering, but again, there's a couple good news and silver lining perspectives here. One of them being once adopted, you keep using it. So as an industry, what can we do to get more and more HCPs under the fold, so that then the more number of HCPs we get, the more longevity we get for that. And then the other thing is that as commercial coverage will grow, the number should start to go up a little bit more, and that our PM and our TM will start to play against each other or positively complement each other, where whether you're adding providers on the RPM side or the RTM side, it'll start benefiting the other code as well. So hopefully there is some benefits in doing that. But all these numbers tell you one story, which is it's a very quantitative story. And I wanted to pair it up with what we see on the field and what we hear on the field, right? What is our day-to-day perspective from the field about this? And how do we think about, why are providers adopting or not adopting? Or what can we do as an industry to support them to adopt some of these numbers? Because we have to bend the curve, right? 1,000 by next year, mid-next year is not good enough. And as an industry, we have to bend the curve. So how do we do that? So what I wanted to do was kind of very quickly share maybe 4 or 5 key perspectives from the field about how we might think about bending this curve as an industry, and how we might support our providers in making sure that they're feeling comfortable and well supported in this, right? So the first perspective that I wanted to share was that the comfort and familiarity of some of these codes continues to be an adoption barrier, right? So that people aren't fully understanding how these codes work. People aren't fully understanding how comfortable, how easy, how difficult these might be. But very slowly, we're seeing that perspective change, right? So one perspective from a revenue cycle management vice president from a really large AMC, they recently told me, and they said, if a new code is not going to generate enough volume, then the effort and cost of training my coders and physicians is not worth it, right? So I need each code to generate enough volume for it to be worth it for me to train my coders and train my auditors and train my physicians and be able to do that correctly, right? If you end up using it for 100 patients, 200 patients, and that a couple docs end up using it, that is just not enough meaningful volume. I'm not going to waste my time on it, right? So one thing that we're learning to see now is, how do you get RCM over the hump? And you get them over the hump by saying that the volumes on these codes will be meaningful enough, right? And another way to think about that is the density of solutions that go into the system, right? So if you have one single solution that only a handful of docs are going to use that can leverage RTM, that may not be interesting. But what if we have multiple solutions in the same system? For an RCM person, it doesn't matter what solution you're using it for, it just matters what billing code you're using. And so now if you have multiple docs and multiple patients and different solutions all starting to come in, that starts to make the volume more interesting. And as a single solution provider, you also want to say, how can we demonstrate enough volumes to make this interesting for people to code under that? The second thing we heard around the same thing was, how the business models need to align for this, right? A chief pop health officer at a very large system in New York basically said, that we've adopted these. We actually have adopted RPM and devices and whatnot. But the problem is that the vendors end up taking a large portion of the money we get on the RPM codes. And so then breaking even on the effort that we have to put into working these solutions is not happening, right? So if you are a vendor and you're going and selling the solution to a provider, and you're creating a business model where you take a pretty big portion of it, remember that they still have to justify putting in all the effort, and that the revenue that they get from the codes after paying you still needs to be worth it. And so that is one thing to think about as we're thinking about going and selling these out, the business models need to be reasonable as we start to sell these solutions. Now, despite the low current use with the numbers that I showed you, there is still openness and excitement, and that is indicated by a couple really interesting signals, right? One is that we have seen precedents for codes like this. Chronic care management codes, CCM codes, were introduced in 2015. They had a lot of restrictions and barriers around it. And slowly what CMS did was lifted these barriers because the data showed that it's a very cost-effective code, right? That what the code was encouraging us to do was actually helping care and was helping deliver care more cost efficiently. And so in 2022, the reimbursement dollars even went up for CCM around about 45%, right? So as data started getting collected, CMS became more open to it, providers became more open to it, adoption went up, reimbursement dollars went up, everything started to go in a favorable direction because we had data now that these codes were being cost effective. So even as a vendor, as you're thinking about this, start to collect data so that you're actually showing that the value you're creating for these organizations is much more than the dollars that you're charging or the dollars that we're charging collectively to the payers, because the payers need to see that to start to make these codes more and more attractive. And we've seen that happen already. There is precedence for it, and we think that it can happen in this industry as well. The other thing that I'm starting to see a lot as well, right, and speaking to a chief experience officer of a large telehealth company, what we're hearing from health systems when they're issuing these RFPs now is to say that the CPT codes are important, right? So they keep asking, like, do you have familiarity with RTM reimbursement codes? Do you have familiarity with helping me with billing on these? Because we want to make sure that we're billing on these. So this particular vendor, for example, has actually created a platform where they can, provide the most up-to-date information and relevant CPT codes and whatnot to these health systems so that they can stay up to date on that. So, but this is all based on health system demand. So health systems are getting sophisticated enough where they're asking for this platform and they're asking for these codes to be set up and for vendors to have familiarity on it. So that's telling us that there is a growing familiarity and that there is an excitement level starting for using RPM codes. The third perspective that I wanted to provide was, the fact that there is the need by hospitals and clinics to have a trustworthy expert in filling the gaps. So one of the things that we heard from, a former executive at Biopharmis, which is a large vendor in the RPM space, was that hospital systems want to speak to the experts within our team. They want to speak to the experts in our clinical teams. They want to build trust with those people. They want to start to think about these teams as an extension of their own teams, right? So when we bring credible clinical teams, for example, or technology teams to bear, then the peers on the other side will look at the depth of our expertise and will engage with us in that way. So one of the things that hospitals are looking for when they're working with you is to say, do you have the same caliber of people on your team that I need to be able to talk and to be able to start to build trust on? Because at the end of the day, this is about patient care. And I want to work with people who understand the importance of what I'm delivering to my patients and the criticality of the services that we're providing. We're also seeing that health systems want a partner in the solution, and that partner needs to provide expertise on things that might be missing on their side, right? So the partnership that a lot of hospitals are looking for example, is around client success and knowing how to set up the program and client support specialists, et cetera, right? So they're investing a lot of dollars in some of these programs. And what they're looking for is, we are very experienced in delivering patient care. We are not experienced in technology, right? And so when they're working with a vendor or they're looking for, can we have a partnership here so that you can fill the gaps in the technology deployment space that we don't have? So help support me with the right level of support. And then finally, sort of really thinking about what are health systems looking for as they're prioritizing vendors? Who do they work with and who do they want to work with? Very interesting quote by this large AMC VP of Digital Health. And they said, I only look for three things when I'm looking at evaluating vendors. Number one, can they integrate into my EMR?
right? I'm not going to ask my providers for multiple screens. We know that already. Everyone in our industry knows that. Second, do you have enough clinical support for my physicians? I cannot ask my physicians to do more clinical work without offering support. And then how do you charge me? Can you create a business model with me that has you having some skin in the game? And what does the skin in the game really look like is the question that you're asking, right? So we want to make sure that they feel like you have enough investment in them being successful. And that is something that they're prioritizing as they look at vendors. And then finally, the dedication and sort of what we're calling white glove service is something that a lot of larger health systems are expecting, right? They want a dedicated onboarding specialist, they want dedicated patient support, provider support, dedicated logistics, all of those things. There's enough vendors today that do provide that. And so some of this is becoming table stakes. But this is also a question that I always encourage companies to think about is, how do you segment the population of providers that you're working with? Right? So how do you think about, will you go for large health systems? And if you're going to go after large health systems, then you have to provide white glove service, you have to provide dedicated service, et cetera. If you go after smaller systems, the expectation on some of this might be different. So right sizing your customer service, right sizing your delivery team, and making sure that this is all working all well together makes sense. And you have to think about customer segmentation for that to happen. So those were really the perspectives, right? So really thinking about who is encouraged to really think about what is provided to them, how we think about providing these solutions to them, how we think about providing value to them. And then how do we take some of those barriers away? How do we make sure that providers are feeling support, providers are feeling that they have white glove service, and providers are feeling that you are a peer and a trustworthy partner in this solution to help them succeed? And then how do you demonstrate to them that you have skin in the game in there, right? So very quick notes a little bit on, what does it take to really think about aligning to the right target customers, and what does it take to align to the right value story or the use case? So I'll start by talking about a case study where some of these things didn't quite work very well. And this is a case study of Proteus Digital Health. Proteus was founded in 2001, a California-based digital therapeutics company, and they developed an ingestible sensor. So the sensor would sit in a pill, you take the pill, and then it tracks your uptake of the drug as it goes through your body. They wanted to use this for medication taking behavior and tracking that, so medication adherence, et cetera. They raised about $420 million. Their peak valuation at one point was $1.5 billion. But then at the end of it, they ended up filing for bankruptcy, and their assets were acquired for about 20 million. So you kind of see the rise and fall of that. And it's a very popular story, but a key points into why the story occurred and why this failure happened is interesting, right? The first thing is the fit with the therapeutic area. They chose to do the initial pilot with a therapeutic area of schizophrenia, right? And so now you're imagining schizophrenia, patients with schizophrenia that are going to be taking a pill that has a chip in it that's going to track the pill, and they have a patch that is reading the chip. For those of you not familiar with some of the key symptoms of schizophrenia, one of the biggest things is paranoia. And so patients with schizophrenia will experience fears and that they're being controlled or monitored by others, and there's a lot of paranoia around that. Psychiatrists were very uneasy about prescribing this to their patients with schizophrenia for obvious reasons. So the fit with the therapeutic area for a solution like this was not perfectly well thought through, and that's an important thing to think about as you're thinking through what therapeutic areas to go after, what clinical areas to go after, right? The second thing, which was really interesting, is the value proposition that Proteus was offering, which is like med adherence, right? There were easier, cheaper ways to determine adherence, and traditional ways within schizophrenia to determine adherence, like pill counting, self-reporting, et cetera, they were there. They were significantly simpler. They were cheaper to administer. And even though Proteus said that this system will end up becoming better, we didn't actually see that in the evidence. So there were no RCTs available that actually demonstrated the level of improved adherence as a result of using Abilify MySide. And so to a lot of providers, it felt like I already know how to do this. I'm doing it simpler and cheaper. It doesn't have the whole concern of paranoia in my patients. And you actually don't have real evidence that this is better. And at the same time, with all of those things in place, the cost of Abilify my site was actually twice of that of Abilify, which was also another barrier. So if you look at this entire story together, it starts to talk about a product market fit problem, right? The product was interesting, I think a real scientific breakthrough, but the way they decided to apply the product to solving a problem felt a little bit underimagined. The therapeutic area was wrong, the unmet need was not clear enough, and the way they were solving the unmet need was not based out of evidence, and yet the cost was double of what we were paying for sort of just Abilify. Andrew Thompson, the ex-CEO of Proteus, came out with a statement after the assets were acquired, and basically he said that at the end of the day, what ended up being his biggest reflection was that he was sort of swimming upstream, right, against the tide within the business models in the United States. So in the US, you get paid for doing more work, and what we were trying to do is we were trying to sort of reverse that. And that just didn't work, and the timing wasn't right, but the business model fit wasn't right as well. So as you, as a solution provider, are thinking about how to really create that product market fit, some of the ways to think about this would be, thinking about therapeutic area, fit with unmet need, the evidence that you're able to build, how the business model fits. So didn't want to leave it at a example that didn't work. I also wanted to give you an example of what has worked, right? And chronic heart failure, congestive heart failure, has continued to be a really, really good success story in the digital health market, right? So if you look at what's happening within remote monitoring users, remote patient monitoring users are growing significantly. And even as we're seeing a decline in the growth rate, it is still a positive growth rate as we see, and as we expect what's going to come out by 2025. About 70 million patients are going to be on some sort of remote patient monitoring, which is an incredible number, and that number will continue to grow. The fit with the therapeutic area in this case is extremely good, right? Payers really care about reduced utilization, so reduced inpatient admissions, ED visits, et cetera. Providers really, really care about this in value-based settings, but even in non-value-based settings, where you're thinking about pure fee-for-service, they're very excited about opening up capacity for higher revenue patients, right? So a CHF patient readmission versus a knee replacement, a hospital will want to leverage a bed for that higher value patient. And so all types of providers are very aligned with making sure that, utilization reduces. Another good thing is utilization is usually an indicator of poor clinical care. So the fact that someone is not getting admitted to the hospital also does mean that we're providing superior clinical care to them, and the patient wins as well. The traditional methods of being able to monitor patients with CHF before remote monitoring came through were definitely inadequate, right? Remote patient monitoring gives you timely, adequate data to be able to make very, very clear clinical decisions that actually have an impact on the outcome of choice, which is utilization, right? So I get data on the patient's weight, for example. I can titrate their diuretic right away and very clearly see an immediate change in their clinical status and prevent an accrual of an inpatient visit or an ED visit, right? So very clear line that we're able to draw from the intervention to the outcome, which makes this so clear in terms of meeting the unmet need. The cost of remote monitoring, again, is a fraction compared to the highly positive ROI that we have from outcomes, because every single visit is $14,000. So as you think about how much the visits cost and you think about how much the remote monitoring costs, it's a no-brainer investment. And enough evidence over the last 15 years has been collected on this, where we're seeing adherence exceed 85%. We're seeing a lot of increased clinical outcomes like exercise capacity, et cetera, significant improvement in clinical quality of life, and the most important one being over a 40% reduction in readmission rates. Which all of this makes it a really, really amazing story for what a provider system will need to do to be able to take care of some of these patients. And all of this continues to drive adoption as we go forward. And again, thinking about your solution and your unique way in which you're positioning it in the market, you want to start to think about how you can make sure these different links are being created. I'm seeing a few questions come up. And so I also want to take leave a little bit of time to take some of these questions. So I'll just quickly go through and do one last bit. But as you're thinking about developing a solution, as you're thinking about targeting some of these solutions, I will often encourage companies to think about segmentation and really thinking about how do you segment your healthcare providers, payers, employers, all your potential customer solutions. And if you remember the perspectives shared so far in the webinar, really thinking about how do you, take your solution, take your current team capacity, take your, customer service and other things, and start to think about how it fits with these different customer segments and providers. A larger system is going to expect more from you. They're going to expect a very different kind of outcome. A value-based organization might expect a different outcome than a fee-for-service organization. So taking your solution, your unmet need, your fit with therapeutic area, and all those other factors, and starting to think about how that applies to these different customer segments will help you narrow down on the right customer segments to go after, right? So you're not using a machete to, kill a fly, for example. And also, as you're thinking about the different customer segments, you also want to think about maybe you go after a couple of different customer segments, but your pitch and your positioning needs to vary by that so that you're actually giving them a positioning that makes sense to their specific needs. So the same solution can be described and can be articulated in different ways depending on what the unmet need is that you're addressing for each of those different customer segments. And it's completely okay and actually encouraged to make sure that you're speaking very specifically about your unmet need and value proposition to these different customer segments. I love an example. So here's another example of Luna, which is a physical therapy service that's delivered to you. I knowingly chose a solution that is not specifically DTx, just to sort of open up our aperture a little bit. But they sell to both health systems and private clinics. So on the health system side, their claim on the physical therapy side is to improve profitability and ensure patient safety and satisfaction with in-home physical therapy. So they claim things around eliminating rehab leakage, improving margin, reducing readmission risk, improving their performance on value-based arrangements. So they actually have data on how some of the in-home physical therapy can improve the performance on value-based arrangements, and then some other ancillary benefits like expanding coverage and leveraging your existing workforce. On the other hand, when Luna goes to PT clinics, they talk about it very differently, right? So they're talking about expanding the reach and profitability of a clinical group by enabling in-home physical therapy for the patients. And so they end up not talking about referral leakage, for example, but they talk about visit volumes. The visit volumes will increase by 10 to 15%. For every 25 therapists added, there's an extra $1 million in value that is creating annually. So they talk about the reverse of what they're talking about with health systems. So they're talking about how can we add therapists to the platform and then increase the amount of value that you're able to get, recapturing lost visits, and then increasing a serviceable area. Because what they're offering to PT clinics is more about how they can attract more patients and how they can expand the footprint, right? So different ways of talking about exactly the same service and appeals very differently to the different audiences. And that's one example of how you want to make sure that your solution is very clearly targeted to your customer segment. All right, so just as a summary, actionable strategies on this and how we can bend the adoption curve. How can we make sure that more than 1,000 providers are going to be under RTM next year? Is make sure that you're segmenting and targeting your customers appropriately based on size, complexity, willing to bill, all those things. Removing of barriers for adoption. So table stakes stuff like EHR adoption, workflow integration, et cetera, are all important, but then also really thinking about business model and pricing model a match. And then finally, surrounding your customer with expertise and support. Very, very important, and depends on the size of the customer. But really, what we're seeing is that systems are prioritizing vendors that have clinical expertise, that have support for things like billing, et cetera, and that have dedicated success teams, because this is all that it takes to make sure that we're getting successful as a provider system, because their expertise is not technology deployment. Yours is. So with that, I'm gonna pause. I'm gonna leave this up a little bit because you can scan the QR code if you want these slides. And then I'll hand it back over to Cassandra to moderate us through Q&A.
Great. Thank you, Kamal. Lots of things to think about. We have a couple of questions in the chat. So going back to the provider survey that you referenced before, Just a clarification question. Was that survey predominantly about prescription digital therapeutics or about non-prescription digital therapeutics as well?
It was all for prescription.
Okay. And do you have any insight into the uptake around non-prescription digital therapeutics that we can share today?
Sorry, can you repeat the question, Cassandra?
Sorry, do you have any insight into the uptake of non-prescription digital therapeutics and how that differs to prescription that we can share today?
Yeah, it's a good question. I think the non-prescription digital therapeutic area is interesting. I think it's being used in a variety of ways. I've started to see it used a lot more in the, when people are deploying through employers, for example. But at the end of the day, it boils down to a distribution mechanism. Sort of how do you want to distribute your solution? And you're totally valid in making it either a prescription or non-prescription, depending on how you want to distribute it. The benefit of a prescription digital solution is that it fits within the current clinical pathways that a provider is already used to, right? And so as a provider, as I'm thinking about my patient in front of me and I'm thinking about my EMR documentation, it's a logical flow for me to say, I've diagnosed you, I've looked at your tests, I've figured out what you need, I've come up with a treatment plan, and this is a part of the treatment plan, and I'm going to fill it. I'm going to prescribe it the way I would prescribe a medication. That's the benefit of having that. Now, obviously, the flip side of that is now you have a gatekeeper, quote unquote, that may not be prescribing a solution that might limit your distribution. So it really depends on the clinical outcomes and efficacy that you have. We don't have a lot of data on the success of non-prescription because it's harder to track what is happening there, right? So I imagine that there is a good amount of uptake, but there is no objective data to look at it yet.
Great, thank you. We have a question around RTM in the chat. So firstly, Jason shared that it's an excellent presentation, but wanted to dive into the idea that RTM and potentially RTM have deductibles and are sort of eligible for co-pays as well. Would that act as a disincentive for provider adoption?
Yeah, it's a really good question. I think with RTM, we have more experience with this. So with remote physiologic monitoring, a lot of what we saw there was that initially when CMS was the only entity that was reimbursing under those codes, especially for Medicaid, we definitely saw a big barrier where we saw that providers were nervous about asking patients for the $8 copay that would have come in, right? And it's a nuanced question because the copay is charged to you only up till you hit your deductible. And for a lot of state Medicaid plans, for example, your deductible is in the $100 to $200 range, right? So in Jan and Feb and March, while you haven't consumed a lot of care, the deductible starts to hit you, but then it stops hitting you. But on the contrary, let's say I initiated the program in October, you won't get hit with the copay for the first 3 months, and suddenly you're hit with a copay in January, and you weren't expecting it because you weren't hit in the first 3 months, right? So there's a lot of nuances around how the patient expectation is from that and how providers communicate this. We also think that the dollar amount, the $8 was small enough at that point where, as a provider system, we would have said, oh, maybe we don't even collect it, but we're not allowed to do that, right? We have to treat all codes the same. So you have to collect what's reasonable on the copay. So that definitely was a barrier in the beginning. And I think another reason why that was not a barrier was because patients were used to getting phone calls and were able to call the clinic and talk to the provider. They were used to getting some of these non-face-to-face mechanisms for free where they didn't have to pay for it. So now for a provider to say, I'm going to give you this device and I'm going to look at your data, I'm going to call you and tell you about this, but now I'm going to charge you money for it. And now you're going to start to see an $8 bill on it. That starts to feel really odd, even from a provider standpoint. So actually, it's a very, very good point. The copay started to be a real barrier in the beginning. Over time, though, now, what we have definitely started to see is that that barrier has gone down a tiny bit. It still remains a significant question that providers will ask us. But that, there's ways to position it and the ways to describe it now. Maybe there's even ways to time it based on the deductibles and time of the year and whatnot, where it may or may not be as big of an issue at that point. But right. I definitely think that for some of these programs, payers should consider taking those deductibles away. Taking the copays away.
I want to stay on this theme of provider adoption. So we talked before about the level of traction we're seeing with providers in the market around RTM adoption. What is the level of traction you want to see for RTM to ensure it could be a scaled solution for the industry?
So it's a good question. I think at the end of the day, you always want to think about adoption in terms of what is appropriate adoption and what's appropriate utilization of a solution, right? So the real question you're asking is what is appropriate utilization of RPM and RTM solutions in the market today? And that's a really hard question because I think it all depends on the use cases that our industry comes up with, right? So if you come up with, if we have 500 vendors today and all those 500 use cases are valid use cases, then to me, every one of them should get adopted and every one of them should have something. But let's just take a little bit of a more pragmatic quantitative approach to that. We think that, close to half of our patients have chronic diseases. A lot of the DTx solutions are focused on chronic diseases. If you look at mental health and the comorbidity between mental health and chronic diseases, that's in the 40 to 50% range. So definitely those patients are very eligible for, solutions like this and for RTM, for example. So I would say that, anywhere around half the patients in this country should be on some sort of digital solution as part of their treatment plan. And I would say that maybe, close to all HCPs should have some experience with using some of these digital solutions as part of their toolkit, right? So, ideally, I'd love to see, about 500,000 providers prescribing on this. And, I'd love to see, roughly, 110, 140, 150 million patients on it. That would be, appropriate based on the use cases that we're seeing in the market and the unmet need that we're seeing in the market. But that'll take us a little while to get there.
I won't ask you to predict the timeline there. I have one more question for us, and I think this is interesting to me because RTM is so new to the market. So I'd just love to hear in your own words, like, what do you think is the main value proposition and value add of RTM, and why is this exciting for you?
Yeah, I think as I described in the presentation, RTM opens up a very clean mechanism for us to get reimbursed to be able to monitor our patients' data that might be self-reported or that might be non-physiologic, right? One of the opportunities that DTx provides that I would say is a little bit missing in remote monitoring is that the DTx solution will often take over the burden of both providing the treatment to the patient and then sort of completing that feedback loop without a lot of involvement from me as a provider, right? So I think that is really interesting, and it's an interesting difference between our PM solutions and DTx solutions. So if we have a way for DTx solutions to sort of continue to work on their own on the patients and then providing me actionable data when I need it, and then I have a way to get reimbursed for that data without having to really, look at the data every single time and respond to it. I think that's great because that reduces my workload as a provider, and that still continues to provide value to my patients. And our TM provides us that opportunity because the data that's coming in is meaningful from that regard. So that's an exciting opportunity. I'm very thankful to the payment group that came up with this new mechanism or billing mechanism, because I think that's really created a mechanism for DTx solutions to get paid for. And I think that over time, as we start to see the success of this, I only hope that the adoption of these numbers will grow.
Great, fantastic. I'm also excited because it's bringing in a whole new cohort of healthcare practitioners that can participate in RTM and RTM.
Yeah.
So thank you very much, Kamal, for a really informative webinar today. As you said, you can scan the slides, get in touch with Decimal Marketing if you have any further questions, and we hope to see you at our next webinar.
And if there's any other questions that we weren't able to get to or that you want to answer, please email us, and we'd be more than happy to answer the questions or jump on call. Appreciate your time today. Thank you.
Thank you, everyone.